Welcome, everyone. This is the final history rounds of the 2025-2026 year, which is amazing. I just want to start today by acknowledging that we are here today on the lands of the Anishinaabe and Haudenosaunee territories. And I always look out of my window this time of year and I see convocation celebrations and all the families coming back. And I always am reflecting on all of the images that must be going through the families and the students' minds as they come back thinking about their time at Queen's. But I also start to think about Queen's from the lens of the people visiting here and seeing them enjoying the campus, walking down to the water, looking at the parks. And I look at those lands from that visitor's lens and I think to myself how lucky I am here to be able to be at the Queen's campus, look at the Lake Ontario and enjoy nature every day. And just want to say thank you everyone for being here today. And really excited to hear Dr. Jordan Miller's presentation. So you might have been here earlier. Chad McClintock did a Methods Monday looking at the process evaluation. And so I am extraordinarily excited, Jordan, to dig in because I haven't seen your full presentation on the final outcomes for this and really excited to see and learn today. So Jordan is a core faculty at HSPRI, an associate professor at School of Rehabilitation Therapy, and he's also the lead of the primary care research excellence cluster here, among many other things. Jordan, I'm going to pass it on to you and excited to hear the presentation today.
Thank you very much, and really great to see so many familiar names and faces around the room. Looking forward to having a good conversation today. And thanks for the warm welcome. Excited to share these results with our HSPRI community. Just share screen here, and then if you could just confirm everything looks okay there, Catherine. All
That's
good.
great, Jordan. Yeah.
Great. Excellent. So please stop me as we go. The joy of these HSPRI rounds is that it can be a dialogue and not just a presentation. And so I'm happy to stop wherever there needs to be wherever there needs to be a pause for a bit of dialogue, and we'll hopefully save some space for conversation at the end as well. And so I'm here talking on behalf of course, like most research, a broad team, and providing first just a little bit of situating myself as a physiotherapist by professional background and health services researcher, as Catherine identified. But here speaking. On work that's been done by a huge team of us, including many members across HSPRI that you can see there listed in the investigator team. The research that I'm going to speak about was funded by the Canadian Institute of Health Research and the Arthritis Society of Canada, and also through AHRQ from Inspire as well, some of the work that I'll speak to. And we don't have any financial interest, conflicts of interest to declare related to the work. So to set the stage for a little bit of the conversation for those that don't live and breathe this space, I thought I better start with just a discussion around where we came from with this work, which is really around trying to address a health system and population challenge around access to primary care and thinking about how we can better leverage a particular profession, physiotherapy in this case, to meet that need. And so this will be no news to the people in this room as I look at your names, but the health human resource shortages globally that are expected to rise, an aging population that leads to more people living with chronic conditions, and a reduced proportion of graduating physicians choosing family medicine has all kind of contributed to this primary care access challenge across Canada, and that's being shared across many health systems. But it ends up, our most recent estimates being about 5.8 million people not having a regular family physician or other primary care provider or primary care team to support them with that longitudinal connections. And importantly, this isn't affecting everybody equally. For example, one of our colleagues here at HSPRI, Iman Biumi, some of her work indicates immigrants and people with lower income, for example, are less likely to have a primary care provider than other people in the population. And this has really important implications on both individuals and health systems. Lack of access to primary care means people are missing opportunities for health promotion and prevention, things like primary and secondary screening, delayed care for certain conditions, people seeking care from other areas of the health system, which are usually much more expensive, and exacerbating health inequities. And so ultimately, this leads to poorer health outcomes and less efficient health systems. And so we started thinking about this question of how can we leverage the expertise of physiotherapists working in primary care teams to help address some of those access challenges and ultimately improve the health of the communities that primary care teams serve. And one way to approach this challenge is thinking about why are people seeking primary care? And so these are the 25 most common reasons for primary care visits. And while this evidence is a bit dated, I don't suspect there's drastic shifts in these conditions. Um, and when you're looking at that list, you can probably think about any health profession from that maybe have representation in primary care and where they could make an important contribution. The other way to look at it is not by condition, which might be how the health professional may look at this data, but the reasons for visit that patients might indicate. And so some of the most common reasons for visit that aren't condition focused are pain, reduced functioning, fatigue, respiratory symptoms. And so when it comes to the physiotherapist question of how do we best leverage the expertise of physiotherapists in team-based primary care to meet that need, there's some obvious conditions. In particular, we were interested in musculoskeletal conditions that make up a substantial portion, probably at least 10% of primary care visits being related to musculoskeletal conditions, or stated more in a patient-centered language, the people that are seeking care for pain or for reduced functioning, where physiotherapists could play an important role. And while I'm speaking about that, of course, that's not all physiotherapists can do in a primary care team, but that's the model that we were kind of most interested in. Important to note also that people with reduced functioning or disability are actually among the most common are most likely to report unmet healthcare needs. And so when we're thinking about access gaps and this reduced functioning component, the particular reason to maybe focus in that area. And so the idea of integrating and leveraging the expertise of physiotherapists, it may be an opportunity to contribute to greater access by offloading other team members in leveraging the expertise of physiotherapists, but also at the individual level to think about these people who have functional or disability needs, who may be the ones most likely to report unmet needs, even if they do have access to a primary care provider. And there's a model that's being used in health systems internationally that is a model that is worth considering in this, and they call it a first contact physiotherapy model of care. And most commonly, most of the evidence coming about this model of care is from the UK. But within this model, a physiotherapist is available as the first point of contact for musculoskeletal conditions, and they have triage processes in place to try to establish processes where and the entry point to the primary care team is through the physiotherapist when the reason for seeking care is a musculoskeletal condition. And the physiotherapist provides a comprehensive assessment, communicates a diagnosis, and then provides a management plan, which could involve some self-management advice, referral to other health professionals, including physiotherapists in the community. It could involve ordering diagnostics, prescribing NSAIDs when needed, providing work recommendations, that kind of thing. And I'll highlight a difference with our model, slight difference with our model related to this when we get to our discussion, but it's got a growing body of evidence related to it, and a recent systematic review on the first contact physiotherapy model of care suggests moderate certainty evidence that diagnostic imaging rates were reduced, and so that's where the highest quality evidence is. Fairly confident that we reduce diagnostic imaging by having physiotherapists available to provide a more comprehensive assessment, potentially than what the average primary care provider is able to provide or fit in to their practice. Lower certainty evidence related to health outcomes, so disability, pain, health-related quality of life. The evidence prior to our trial was a bit lower certainty, but it certainly looked like there was no difference, that there's similar health outcomes across usual care models that involve a first point of contact with a family physician or GP, comparison to the first contact physiotherapy model. And very low certainty related to costs. And so that brings us to the main thrust of the conversation today, which is about what was the impact of a physiotherapist-led model of care for musculoskeletal conditions in Canada. So one, we wanted to test it in the Canadian health system. Two, we wanted to overcome some of the lower quality or uncertainty in the evidence of the global evidence, and within that, test a model that really fit the Canadian system. And so we carried out two cluster trials that had very similar objectives. The first objective was to estimate the effectiveness of the physiotherapist-led model of care, and the primary outcome was functioning or disability. And we had a number of secondary outcomes at the patient level, evaluated over a 1-year period. The second objective was to estimate the impact of the model at a health system and societal level. So we were interested in things like how does that impact access at the team level, and cost effectiveness at the societal level primarily, but also at the health system level. And I won't do a deep dive into methods, but encourage you to seek out the Methods Monday that Chad gave, because he did a wonderful presentation on cluster trials and some of the decision making that we went through in deciding about this about our trial design and some of the decisions that we made within that design. But there are two trials. The first was funded by a CIHR project grant, and it was focused on back pain. And the second trial was funded from CIHR and Arthritis Society and was focused on hip and knee, people seeking care for hip and knee pain. They were both parallel cluster randomized control trials where the primary care clinic was the unit of randomization, and we randomized a clinic to either carry out the physiotherapist-led primary care model or continue with usual care. They both had a 12-month intervention period, so the physiotherapist was added to the team for a 1-year period, and the physiotherapist was available for a full year to the patient from the time they sought care for their condition. The difference between the two is for the low back pain trial, we had 20 clusters, 14 in Ontario and 6 in British Columbia. And for the hip and knee trial, our sample size calculation revealed we could carry this out with just our Ontario sites. So the 14 sites are shared for the two trials, and the 6 additional sites in British Columbia for the back pain trial. The primary outcome was functioning and disability for both, but for back pain, the region-specific functional or disability questionnaire is called the Rowland-Morris Disability Questionnaire. And for the hip and knee trial, we used the lower extremity functional scale. But as you'll see there, the secondary outcomes and cost outcomes were quite similar across the two trials. So what were we testing? What were the interventions that we were comparing? The physiotherapist-led primary care model for musculoskeletal conditions involved adding a physiotherapist to a team that did not have a physiotherapist at the beginning of the trial. So an important piece to note. It was the physiotherapist was available as the first point of contact within the team, and available through direct access for follow-up appointments during the duration as needed. We didn't extend scope of practice or delegate any controlled acts. And then there was 4 core components as we thought about the design of the model. The physiotherapist performed the initial assessment and screening, provided a brief individualized care at the first visit to all patients, which involved some evidence-based care like providing cognitive reassurance, making sure the person felt listened to and heard, self-management supports, and exercise that could be provided to the patient participant. It was then the goal that the physiotherapist would connect the person to the community resources that are appropriate based on that assessment. And so that could involve referral to a physiotherapist if ongoing care was needed, if there was social or social needs or other health needs, they might provide connections to other health services, either within or outside of the team. But it bolded there the core difference from the first contact physiotherapy model that's tested and implemented in the UK versus the model that we implemented here in this trial, which is about part of the goal was about addressing unmet need for ongoing care. And so in our model, that physiotherapist, if they identified that the person would benefit from some follow-up visits beyond the initial first contact role, then they were able to provide those visits with the goal of not duplicating any services already available to the patient. So if that person had private health insurance and availability to reach somebody working in private practice as a physiotherapist, for example, they would make that referral. But the goal was to address the unmet need for anybody that would benefit but didn't have access. And that's different than the model in the UK, where actually there's already universally accessible physiotherapy across the health system, where there wasn't necessarily that same unmet need. And so it's a different model here in Canada. It's part of why we kind of went against the grain in labeling this a different name than the first contact physiotherapy model of care that's used more commonly throughout the literature. To explain our Canadian specific model. And usual care was very unstandardized. We wanted to monitor what was happening, but we didn't want to influence what was happening to best reflect care in the Ontario and BC contexts. And so that usually involves the physician or nurse practitioner as the entry point to the team. And most commonly from both our pilot trial and our full trial, that often included medication prescription, diagnostic imaging requests, referral to other professionals, and would involve access to any physiotherapy services that were already available through referral from the physician. So what did the results say? Well, first, let's look at what was implemented. Did we actually change care? Because one possible outcome is we add another team member and the care looked the same. That didn't happen here. When we look at on the top left, we're looking at the low back pain data. And on the bottom right, we're looking at the hip and knee trial data. And what you'll see when you look at rate ratios is the proportion of people that received these care. As a rate. And so you can see from that data that in the back pain trial, people were less likely to receive an NSAID, more likely to receive structured or documented exercise, and more likely to receive exercise as part of their care when their physiotherapist was added to the team. And those were part of our logic model for the program. These are the exercise and education was to get people access to that. The unintended observation was the reduction in NSAIDs, which is also an evidence-based recommendation for low back pain. Also importantly, we saw a reduction in some of the things recommended against by clinical practice guidelines. So medications such as opioids or muscle relaxants, which aren't recommended for back pain, we saw a reduction in those in the physiotherapy-led model of care for back pain. And similarly with other medications, actually with other medications, it was similar. In the hip and knee trial, we saw a different pattern. We didn't see a change in NSAIDs. We didn't see I guess we saw a slight increase in the education, but a substantial increase in exercise, and no difference in the medication prescribed. So we did influence some of the things we were trying to influence. One of our hypotheses was that people would get more guideline adherent care if the physio was added to their team, in particular thinking about exercise and education. And so what did that do for outcomes? These are our primary outcomes. And on the left, again, is the low back pain trial. And on the right is the hip and knee trial. And so lower is better on the Roland Morris Disability Questionnaire. And so what you'll see there is that the physiotherapist-led group is the blue line. And we see significant differences and greater improvements in the group that had the physiotherapist-led model of care. In comparison to the group that continued with usual care. In the hip and knee trial, on the other hand, we didn't see significant difference between groups. Those lines are pretty close to on top of each other throughout the study, and so showing no difference in functioning outcomes between the two groups for hip and knee conditions. See a very similar pattern across a number of health outcomes. And to show one, this is the EQ5D, which is a quality of life measure. And similarly, we show significant improvements in quality of life in the low back pain trial and no difference between groups in the hip and knee trial. When we look at some of the other secondary outcomes to not show repeated graphs across all of our outcomes, we see quite a similar pattern actually related to, for example, the low back pain trial showing improvements in self-efficacy, catastrophic thinking and fear of movement as risk factors for ongoing pain and disability, improvements in depressive symptoms and pain during activity, whereas we saw no difference in each of those outcomes in the hip and knee trial. what was consistent across the two trials is that patients were more satisfied with the care they received, and the global rating of change was improved in both groups, and there were no difference in adverse events across either group. I'm not going to spend a lot of time on this because I want to allow time for conversation. But of course, I didn't want to walk through the story of this without talking about the experiences, which are really important. And so this is a work of Geneviève Bacchus, a PhD student in our work that's exploring the patient experiences. That's a poster that she shared recently at Casper, and it essentially shows some themes related to easing access to care and the importance of that co-location and being embedded within the team related to that. This kind of dual perspective on comprehensiveness of care, where on one hand they felt like they had this added expertise to the team, but on the other hand feeling like there was a bit of worry around missing out on imaging and diagnostics that they might miss out on through the model. People felt like they had more choice and autonomy in their healthcare decisions. The physio being added to the team felt like it gave people choice of being able to make the decisions, where sometimes that felt out of their hands prior. Um, the idea that their healthcare providers were working together was something that was highlighted, and the EMR in particular, patients felt like that was something they saw in the back pain trial in particular, and feelings of empowerment through the care that they received. Similarly, Mir is here today. I see him in the room, but his work's been exploring the physiotherapist perspective, where we're seeing a number of themes related to that. And I won't unpack the details, but send me a message if you want to hear more. Where I will dive back into what our trial results show is the impact on primary care physician or nurse practitioner visits. And this is what we would consider a proxy measure for the capacity of the team to increase access. So the idea that the mechanism through which we could improve access to primary care is actually offloading visits with other team members who might then be able to either provide more access to existing patients or potentially roster more patients based on the reductions in visits. And so what we saw in the low back pain trial was about a 30% reduction in physician encounters amongst the people with low back pain who were seeking care, and about a 50% reduction in administrative tasks that were documented within the system, things like referring for imaging or receiving imaging and interpreting that and creating a plan. In the hip and knee trial, we saw no significant differences in physician encounters or administrative visits. The next question we wanted to ask was, what is the impact on occupational activities in terms of days missed? And what we saw is a significant improvement in the physiotherapist-led model of care for low back pain, and no significant difference in the hip and knee trial, with people missing fewer days of occupational activities in the low back study, and people missing a similar number of days. There is a possibility that there was a difference there that was underpowered to detect in the hip and knee trial, but certainly seeing a bigger rate ratio estimated there in the low back pain study. Also, we were interested in the impact on healthcare utilization. And so again, on the left is the low back pain trial. We saw no difference in emergency department visits when the physiotherapist was added to the team. We saw no significant difference in physician specialist visits, but this is probably one where we're not certain if there truly is no difference or if we were underpowered to detect that difference. Similarly, with surgical procedures, we see fairly a low rate ratio of 0.44 as a point estimate, but a wide confidence interval. So we can't be confident whether there truly is a difference or isn't, but it seems, oops, sorry about that. And then other injections and procedures outside of surgeries, we see a significant reductions in those. So things like ablations or injections being most common in back pain. And similar to the existing literature, just strengthening the literature that already existed, is that that there was a reduction in diagnostic imaging ordered when the physiotherapist was part of the team. And then when we look on the hip and knee side, we see similar trends of no difference in ED visits the physician specialist visits potentially being no difference or being different with underpowered to detect the between group difference. A similar trend with surgeries and no difference in injections or procedures for the hip and knee conditions, and again, diagnostic imaging being reduced. When we put all of this together in terms of what does this mean for cost to a system or to a society, actually, so this is our societal outcomes, which is our primary way at looking at cost effectiveness. For those who haven't looked at graphs like these before, the x-axis is our incremental quality adjusted life years. So as you shift to the right on these, that's quality adjusted life years gained with the PT-led model of care. So that's an improvement in quality of life. And vertically on the y-axis is the incremental costs. So lower is reduced costs and higher is increased costs. And what you see in the low back pain graph, which is the one on the left again, is what's called in economic analysis a dominant pattern, which means the physiotherapist-led model of care both improved health outcomes for people seeking care for back pain and reduced costs. And on the right, we see a little less certainty where the estimates are crossing the quadrants, but the most likely scenario in that graph is that it reduces costs and results in similar outcomes. So you can see vertically or in the horizontal axis, the red dot of the point estimates almost right on the vertical line, but the point is below the horizontal axis. So that being the most likely scenario, but less certainty for sure in the hip and knee trial. And the other way to present this data is a willingness based on willingness to pay threshold. So in these graphs, the willingness to pay is across the bottom. So that might be a health system decision where in Canada, $50,000 is sometimes used as a willingness to pay threshold. So for every quality adjusted life year gained, you might be willing to pay $50,000 for that quality adjusted life year gained, although there's no firm policy on that in Canada. And on the left, you can see, again, the dominant pattern where regardless of willingness to pay from $0 to $50,000, there's over 99% probability that this is a cost-effective model. And on the right, we see a little less certainty where if the willingness to pay was, 80 or was 0, then we're 80% or almost 80% confident that this is a cost-effective model, and a little over 60% confident with a $50,000 willingness to pay threshold. Of course, any trial or any study, there's limitations, but the particular limitations in this cluster trial was that we recruited participants after cluster allocation. And one of the challenges with that is trying to balance recruitment between arms. And we had more recruitment in our physiotherapist-led arms than our usual care arms across both studies, which does point to a risk of selection bias where there might have been differences in how consistent the screening criteria and recruitment was happening across the sites. Mitigating our concerns about that risk of bias is that both groups looked similar at baseline in terms of all of our prognostic indicators and our outcome data. So that hopefully gives us some strong confidence in our results. What we're unpacking now is our process evaluation and thinking about how was the model implemented and what are the ways it could be optimized further for future scale and spread. What are the mechanisms of the model of care, in particular that the difference between the first contact access part of the role versus the providing unmet or meeting unmet need part of the role, which is different than other models that have been tested. So trying to understand that from all our different data sources. And understanding the barriers and facilitators to implementing the model will be a really important place that we go as we start to inform what it might look like to scale and spread this model. So the last topic in our HSPRI community, I thought it'd be okay to speculate or extrapolate a little bit more in this section of the study, because I've presented the trial results before, and we're pretty confident in what we're presenting through this. And I appreciate I just flooded you with information, but I thought it'd be fun to have a little bit of a discussion around like what would this mean at a practice level, and what would this mean at a provincial level as a way to look at the potential practice and policy implications. So I took a family health team with 45,000 patients as an example. And if we tried to say, what would we look at? What would we see if we implemented this model for all musculoskeletal conditions? And making some assumptions that the averages between the low back pain and the hip and knee pain would be what we would apply across the musculoskeletal conditions. So some assumptions in there, but ones that I think are fairly reasonable. And so within a team of 45,000 patients, 20% would seek care for musculoskeletal conditions each year, which would be about 9,000 people seeking care every year for musculoskeletal conditions. If we take our data on health outcomes and we look at the proportion of people that experience a meaningful change, 419 people every year would experience a meaningful improvement in functioning if they had a physiotherapist-led model of care implemented within their team. If we take the data related to physician or NP visits, we would see a 41.5% reduction in musculoskeletal conditions, which actually represents 4.4% of all visits in primary care could be reduced with implementing this model across that team. And a 32% reduction in the administrative visits associated with the musculoskeletal conditions. This is where there's a bit more of an assumption is about what would that mean for rostering more patients? If the goal, which seems to be the case across a number of provincial health systems, is to leverage team members to increase the capacity of the team to roster more patients. So, there are multiple access goals. It could be about improving access for people that are already part of the team, but this is making the assumption that the goal is to attach or roster more patients. And the calculation that I used to do that is that the average patient in any given year sees their primary care team 3.8 times. And if we assume, therefore, that every 3.8 or 4 visits per visits with the family physician or nurse practitioner would allow a rostering of 1 additional patient, we could see that that team might be capable or have capacity then to roster an additional 1,977 patients if they had the physiotherapist-led model of care implemented. Taking this one level further, we also, through our AHRQ, we were able to look at why did people continue to see their physician or nurse practitioner after seeing the PT. And what we realized is that there was a subset of those visits that were only to get an image ordered or only to get an NSAID or only to get a referral. So we also took the step of looking at what further impact could we have if those policy barriers were removed to allow the physiotherapist to practice to full scope, which they can in other jurisdictions outside of Ontario or BC. And what we could see, instead of a 4.4% reduction in total visits in the primary care team, we'd see 8.1% total reduction in primary care visits amongst the team. And if we spell that out again to the number of rostered patients that may ultimately lead to, instead of 1,977 extra rostered patients, it would be 3,659 extra rostered patients. So you can see the real policy implication of a scope of practice here in the primary care context related to being able to order the image, recommend the NSAID, and refer to a physician specialist. We're still working on unpacking and Chad's here. Chad's working on unpacking. When I say we, I actually mean Chad's working on this at the moment. It's trying to tease out what each of those policy decisions might lead to. Right now, they're kind of grouped as to what would be the total extra capacity of the team, and what would be the impact on costs to our health system and to our region. And so what we would see if this model was implemented just with this one team of 45,000 patients, we'd see a $2 million reduction in cost to our public health system. So it's just Ontario health payer perspective. And we'd see an $11.5 million savings to our societal outcomes within our region. And so that main difference between those two numbers is that people are getting back to work faster or missing less occupational activities where there's that many savings. So often this argument is framed as can we afford to invest in these teams? But when I look at this data, I can't help but reframe that to say, can we afford not to not be doing this, because we're paying a whole lot more for the way we're providing care currently than we would be if we were implementing this model of care more widely. Here comes the challenge. seems straightforward based on the data. We should scale and spread this model widely. But for that team of 45,000 people, within our trial, we saw 3.2 visits per person on average, which would mean we'd need about 7.5 FTE physiotherapists to meet the needs of a big team of 45,000 people. So that's a challenge in terms of being able to scale or spread the model. And I thought we'd go one level further and say, what would this look like at an Ontario level? What if Ontario decided this was going to be a policy change to invest in this model of care across the province? The impact on health outcomes would be that 161,000 additional patients would experience a meaningful improvement in functioning or disability every year if the model was scaled and spread. That 8.1%, that 4.4% reduction that we talked about in physician and nurse practitioner when scaled across the province could lead to a capacity to roster an additional 707,000 patients to primary care providers. And if we remove the policy barriers to practicing to full scope in terms of ordering imaging, recommending NSAIDs, referring to specialists directly without needing to revisit their physician, we would see a capacity at using that 3.8 visits per person as the math related to that of over 1.3 million patients being able to be rostered based on the percentage of visits that were offloaded with that. So substantial, meaningful change when we look at it. We think about one group of conditions like musculoskeletal conditions, and when we scale that proportionally, it can be substantial in terms of meaning. And lastly, what would be the impact on costs? And so the costs of musculoskeletal conditions using our trial data is the estimated cost per person and extrapolating that to across the province of Ontario. We would see with the physiotherapists added to the team, $745 million in cost reductions to the Ontario health system. And if we look at societal costs, which includes missed occupational activities, we would see $4.1 billion in societal costs savings with the implementation of the model. But again, the challenge comes up. What would be required to scale that model would be 2,862 FTE physiotherapists to scale and spread the model, which sounds like a lot, but actually proportionally isn't quite as scary as I thought it might be when I started doing this math. But of course, there's lots of challenges to think about where they distributed and how we distribute them equitably, and like lots of human resource challenges to thinking about what would this look like to implement more widely. And so, to summarize some of that speculative math around what would be the policy, like the implications at a practice and policy level, I think there's a number of things that would need to happen. One, there would need to be a funding decision to increase the number of physiotherapist positions allocated to primary care teams across the province or across the country. I used Ontario as an example, but of course this isn't Ontario-centric specific. It was just the math that I chose to highlight based on our current location. Second, there would need to be create strategies to fill those primary care roles. That's a lot of physiotherapy roles based on the number of physiotherapists. So we'd have to be thinking about increasing enrollment in physiotherapy programs or facilitating easier transition of internationally educated physiotherapists. And we'd have to overcome some of the barriers to people applying and staying in these positions, which in particular, pay scale that is inequitable with other areas of the health system is a challenge we hear about from lots of our primary care partners, where, some examples that we've heard about is that physiotherapists working literally across the hall from each other in a dual family health team hospital setting are making, tens of thousands potentially of dollars more in the hospital side than they are in primary care. So that would need to be addressed, I think, to fill the positions. The third thing that I think that would need to happen is preparing the physiotherapy workforce for primary care. And MIR's data on the experiences of primary physiotherapists in this role starts to highlight some of the things that physiotherapists said they needed to learn more about. They talked about connection with community resources in particular, feeling like you need to know your community at a level that you don't maybe need to know the same degree in other areas of the system. Complexity of working within primary care teams, and how do you build trust and relationships? How do you collaborate well within primary care environments? Those things I think are things that we would need to help prepare the workforce to maximize the contributions in the role. And the fourth is about removing barriers to practicing to full scope. As I started to speculate a little bit related to the number of visits we could further reduce if they weren't going back to see their physician or nurse practitioner just for an image or just for an NSAID or just for a referral to a rapid access clinic for their knee arthritis. Those types of things. That we could maximize their contributions there. So I think those are some real, policy and practice implications that I think need to be thought through. Um, my acknowledgements are a huge thanks to the two funding organizations who funded this work, CIHR and the Arthritis Society, and I didn't add to this last slide, but mentioned them at the beginning, the AHRQ through the Ontario Ministry of Health as well, and administered through Inspire. Uh, the investigator team, as with most projects, with a huge collaborative level of expertise from each one of these team members and partners. We had 20 primary care organizations that were huge contributors to this work, and knowledge users who have helped inform both the design in the early stages and now in the thinking about interpretation and knowledge mobilization. And our patient partners and who have been involved all the way through, and the over 1,400 patient participants who volunteered their time to complete follow-up assessments and contribute to this evidence. I didn't leave quite as much time for questions as I thought, but I was only 5 minutes over what I intended. So looking forward to hearing from you and having a chat.
Well, Jordan, that is impressive on many, many levels. One, that you stuck to your time, like, because you went through a lot of information there, which is impressive. I'm just gonna like say a few things. Just partly is a wonderful presentation, really set up the problem well in terms of, what are the issues that the system's facing, how can that be addressed through a specific intervention. I love the walking through all the way to the end in terms of the policy implications and thinking small, but also then expanding it out. I think it makes it palatable in terms of thinking about policy changes to imagine what can it look like at one small level. And teams can make those decisions themselves. That's why I really love that. Um, and it's really duly impressive to think how you've systematically broken down MSK both into hip and knee and back to show that when we lump and clump, it's not always the same, and you're able to tease out different outcomes by looking at those two groups differently. I'm just so interested in why you think, like, why. Like, I have a whole bunch of things in my mind, but I mean, just the fact that you separated them, I think is so fascinating and so excellent. And I think this whole study is a template, frankly, that every one of the professions that are working in team-based primary care needs to replicate around a population to show the government what you could do by systematically leveraging your team.
Uh, Thanks for the kind words and the you statements. I will say we statements, Catherine, because you were an important part of this team too.
Well,
And I love the speculation. I wondered where to direct the conversations in different presentations because one of the focus of the discussion we had at CPA Congress, where the audience was physiotherapists, was largely around unpacking this difference because I think it is so fascinating, isn't it? Like it's so unexpected.
hmm,
I probably, if you would have asked me, I tried to approach it with equipoise. But if you asked me ahead of time, I would have probably predicted no health outcome differences in either study, but that
hmm,
there would be some cost and health system savings through doing it. So the surprise was actually this like
hmm.
the significant
That's amazing.
benefit in the back pain across multiple outcomes.
Yeah.
For me, that was like the
Mhm.
surprising piece. And why do we think that's the case? Why did that happen in the and but it was consistent about
That's crazy.
utilization measures and stuff too. So
Yeah,
it's fascinating.
amazing.
My working hypothesis, which is needs to be unpacked in our process evaluation. So at this time, it's very anecdotal. one thought is that is that the invisibility of back pain and all of the uncertainty
Mm,
around that means that the time the physiotherapist spent listening, providing cognitive reassurance, trying to reduce some of those negative cognitions associated with
mhm,
back pain, may be more likely to be effective in the back pain population than in the hip and knee population. So that's one thing that I'm interested in thinking about as one potential explanation. The other is potentially like what usual care looks like and how hard it is to change usual care. um, and so thinking about the hip and knee side of that, like there are effective interventions like surgical procedures like the hip arthroplasties and knee arthroplasties um, and there are medical pathways well established for hip and knee, even if they didn't get a surgery during that 1 year window, like they feel like there's directions in those pathways
yeah,
that would a be well ingrained and hard to change, and that maybe a lot of people ended up down those similar pathways, but B, that there's some effective, interventional things um, for hip and knee that maybe just we weren't able to change. And then the third thing I think about is um, for hip and knee conditions in particular, we know exercise is effective. Like there's
right.
really longstanding and well-established evidence around that, and we increased it by 13-fold in this and didn't change it. Maybe one-on-one care is not the best way to create
Mm,
behavior change related to exercise, as
mm,
the other thing I think about. Maybe we overtreated those folks in the hip and knee study, and that we would be better off.
mm,
I'm generalizing hip and knee conditions to osteoarthritis, but I assume
right.
that's the bulk of what we saw, and maybe offering a GLAD program,
Mm,
an evidence-based group
yeah.
exercise program where people can connect, would be a more efficient way to deliver care. And so the physio might shift the role from, being that entry point, still being part of it, but actually like maybe visiting them 3 or 4 more times for the people that didn't have access, maybe didn't create change. So anyway, there's my speculations, but I'd love to hear other speculations on that or yours around potential reasons why we might see these differences. Hmm.
Yeah, I have like a whole bunch of questions, but I don't want to like hog the floor. I know there's other people here, and if people have questions of Jordan, partly we are deep into summer right now, and the beauty of the HSPRI rounds is that they're made to put onto YouTube, so we'll be putting these out as well. There'll be lots of interest. Um, did Stephanie? Okay. Stephen asked his yeah. Jordan, I'm going to ask actually about the psychology.
Hmm.
Because I thought that was actually really interesting too. And I wonder if that's, I guess, what you're getting at too, the complexity of low back pain. It's hidden. People have their stigma associated with it. People don't feel heard specifically. Um, and I just wrote down there was there was a much higher proportion of people going to the psychology I saw, and I was intrigued by that, just thinking about this idea of like something about low back pain being complex and like needing other team members too and
Hmm. Well, I think about that most in terms of the first, like the implications of like how do we understand what actually got implemented and how do we improve it.
Mm,
So one of the things we noticed is that there was lots of electronic health record chatter between the physio and the physician. What
interesting.
what there was not is
Mm,
communications between the physio and other team members at sites where there
interesting.
were other team members. Now there were some that there were small teams and it was,
Right.
physio was added to physician nurse, but there were other teams where there was a complement of team members there. And I think it was in the order of like I want to say 1.2% of
Mm,
patients that there was a communication between the
wow.
physiotherapist and somebody other than the physician or nurse practitioner. That is very like I don't know what the right answer to the percentage would be. There's certainly a subset of these groups that they can
Mm,
likely manage themselves and offload, but I would expect it to be much higher than
yeah.
1.2%. When you think about the complex, interaction between, um, yeah, mental health conditions and back pain, for example, I would expect that there would be a huge opportunity to leverage occupational therapists or social workers or psychologists, depending on the team who's available there for some of the complex pieces. Like we had yeah,
Mm,
1,400 over 1,400 patients across the two studies, and you'd think a little bit higher proportion of those would
that's
have
shocking.
benefited from team-based care. And so it comes back to that some of what we're hearing from physios is I think we need some capacity building to do in terms
Mhm.
of what it looks like to move into those roles, because it sounds like there was probably some missed opportunities to do more in terms of leveraging the other team members, right?
Yeah.
To provide more comprehensive care.
And I wonder if it's in some ways like that is interesting. I think that's probably also a little bit of a microcosm of what we're seeing teams not necessarily being teamy, as we say, but also wondering because they weren't part of the everyday team. But that being said, they're interacting with the physicians and NPs. I have another question about administration, but I'll pass this on to Shara Rose, who's got a question.
Thank you, Jordan. Excellent presentation, excellent study, and the findings are, in some ways, a bit mind-boggling.
Mhm.
Uh, but I think, you've said this a couple of times about offloading, and I think what I'm hearing is actually task sharing, right?
Mhm.
So I think the language is
Mhm.
really important in that the right person be with the right individual to provide the right kind of care, like that kind of thinking. But
Mhm.
then there are instances where they become sort of the background, and the physician becomes more in the forefront, right? So
Yeah.
I think maybe um, task sharing would be a better way of languaging this, and I think it also then, when you're thinking about building capacity and building that workforce, the value of the work becomes important. It's not like um, you're I don't know how to say it, but um, that you're just giving this off because you don't want to do it, kind of thing, right?
Yeah, this is a really great conversation, Chad Rose, and I'm glad you raised it. It'd be interesting to hear what you think of when you hear these two terms or three terms. Catherine added one more in the chat around task shifting, task sharing, task shifting, offloading. And it was probably quite unintentional of me using the term offloading, and it probably came from the idea that our proxy measure for increasing capacity was reducing, right? It was about the reduced number of physician and nurse practitioner visits, and I probably, could have used the precision of language of that rather than shifting my terminology to offloading. But when you say task sharing, I guess I would love to hear your thoughts of when you hear those two terms, how do you differentiate them? Other
Yeah.
than other than language, like do you conceptualize them differently, offloading or task shifting, which might be similar, versus task
Yeah.
sharing?
Yeah. And I think I come also from a low and middle income perspective, right? So for task shifting is that you don't have the care provider there to begin with. And so really you then um, train up a lay individual to deliver the care, because the resources are not there. And I think for me, task sharing is more about a shared responsibility where different individuals have different levels of responsibility in the care. And depending on the patient's condition, that level of responsibility may shift from PT to physician to specialist, right? And so that's why I think, for me, I think more it's a shared care model because also the patient has a responsibility and also has a shared responsibility in the care. So
Yeah.
that's where my thinking is
Yeah,
at.
yeah, I love that, and I'd love to continue unpacking that with you around the use of the terms and the meanings of those terms. I do I don't love when it comes to back pain and musculoskeletal conditions, the idea of stepped approaches, I think, are a bit flawed a lot of times. And so that language of level of care going from physio to physician to specialist implies a level of hierarchy of care or step care that I think is problematic in this context. But I love the broader idea of what you're referring to of the task sharing and whose responsibilities, who all could complete these tasks, whose responsibilities are they, and especially the fact that you put the patient in the center of that, are part of that task sharing piece. Anyway, love the language that you're going. I feel like I've got some unpacking to do that I'd love to do as well around the use of these terms.
Well, and it's so interesting. I know Jordan and I have like lots of sidebar conversations about all of these concepts in teams and how do teams function and how do we describe how to be most efficient in terms of our resources and models of how people access the different team members in primary care explicitly. What does it mean to be able to contact anyone in the team directly versus being triaged versus referrals, and should we be using the term referral within a team? Like, aren't we just all working with the same folk? And but I think that really designates these structures we have in our head about, whose person it really is, and to the point of care. Well, I guess it's the MRP concept, right? And it's not that there isn't a most responsible provider, but how do the rest of the team fit in that sort of vision?
Yeah. And I know we're getting towards the top of the hour, but I think Stephen's comment makes a nice place to round off this conversation, which is the idea of interprofessionalism versus multi-professionalism, and the idea that, the offloading language might be associated more with a multi-professional rather than interprofessional model. And what our goal was with this model of care was certainly not uh, and like replace the team with the physio. It was to change the front door of the team to the physio, that they enter the team, and that for a number of places they may only sit in the, in the first room they come into within the house with the physio for a large portion of people, but that the physio would help them, through the rest of the home, get connected to others. And what we may be seeing is that the interprofessional the interprofessional teaming didn't happen the same extent that we hoped it would in the model, and that maybe that's where we've got some additional work to do. And where I've got additional work to do is refining the language related to what we're gonna refer to these as.
Well, we're learning from you, Jordan, because we haven't, after 20 years of the family health teams, done enough to unpack like all the different populations and how different team members can best support different populations. So this is phenomenal. I'm just looking, or at the top of the hour, but thanks so much, Jordan. Really, truly impressive work. And I know it's many years in the making, but really impactful. Thanks very much for spending your Friday with us, everybody. Take care.
Yes, thank you, everybody.